Good morning, and thank you for the opportunity to be here. So I've been asked to talk a little bit about trying to understand HTE within the context of two trials related to intensive blood pressure treatment. I am used to putting a disclosure slide, so I have no conflicts of interest to disclose. From the perspective of a primary care physician like myself, an interesting problem is the seemingly simple task of treating blood pressure, which we should, in theory, know how to treat after so many years. And an interesting dilemma was posed by two trials for which the conclusions to the abstract read as follows. In 2010, a wonderfully done, multinational, well-conducted, randomized trial compared a seemingly simple question: should we treat patients to a blood pressure of 120 or to 140? And the conclusion read that targeting a systolic blood pressure of less than 120 as compared to less than 140 did not reduce the rate of composite outcome of fatal and non-fatal major cardiovascular events, myocardial infarctions and strokes. A few years later, another well-conducted, large, multinational randomized trial published in the same excellent journal concluded, as the last sentence of the abstract, targeting a systolic blood pressure of less than 120 as compared to with less than 140 result in lower rates of fatal and non-fatal major cardiovascular events. The first trial, the ACCORD trial, was among people with type 2 diabetes, and the second, the SPRINT trial, was not. But other evidence from a number of trials did not suggest that diabetes was necessarily such a profound effect modifier as to explain this discrepancy. And so one was left as a provider with a variety of possible options. Should we trust one trial over the other? In fact, in ACCORD, there was some signal towards higher mortality from 120 being somewhat concerning. Editorials were in a number of different directions, and so this was a potential conundrum. We could say it was random chance. We could say it was due to differences in sampling, and perhaps the diabetes was the effect modifier despite a number of other trials suggesting not. Or perhaps one hypothesis is that HTE exists, and despite being part of an overall similar population, differences in sampling result in somewhat different average treatment effects between the trials. A result from the SPRINT trial, the latter trial, showed the comparison of the intensive, meaning less than 120 arm versus standard. But it's notable that this is not such a benign choice for the primary care clinician. Rather than simply being a matter of causing some nausea or headache, the side effects of intensive treatment may in some cases be severe: hospitalization, disability, dialysis, and death. So one would want to make the right answer, even though blood pressure may seem like a fairly benign treatment decision. So we wanted to ask, could we in fact explain the discrepancy in average treatment effect between the trials by thinking about it in terms of HTE? Perhaps similar patients in predictable ways have more benefit than risk and vice versa, and differences in sampling could lead to differences in the average. And hence in the clinical realm, we can actually reconcile the purported discrepancy between the two trials. So we developed the following a priori analytic approach. We thought we would train two Cox models, one for benefit, meaning a reduced absolute risk of cardiovascular events and deaths, and one for harm, meaning an increased risk of the severe adverse events, hospitalization, disability, or death. We chose a limited set of potential candidate variables for these models based on some prior literature suggesting what might be reasonable HTE factors, omitting a number of others. In addition to study arm with those key interaction terms suggesting HTE, we included demographics, tobacco use, and some pre-randomization laboratory medicines and blood pressure levels. And we used an approach that essentially tried to do two things. We noticed that there was a lot of collinearity among the variables, as is understandable given cardiovascular risk and our understanding of it now, and noted that in a typical approach, for example, stepwise or backward selection with information criteria to choose key variables in a model, that the collinearity became problematic, and I'll show you some of that in a moment. It essentially miscalibrated models. And instead, we used an approach that tries to say, in the presence of many collinear variables, can we choose either one that represents the other collinear variables, or shrink the coefficients to be similar among very collinear variables, such that outliers perhaps will have less influence. And then we did some repeated cross-validation, meaning subsamples of the data were selected to try to build a more robust model. In our a priori specification, perhaps this could have been revised in retrospect, we chose to try to maximize how much we separated people in terms of net benefit, the predicted benefit minus predicted harm, and externally validated on the Accord trial after developing on Sprint. We also did a few post hoc, not pre-planned analyses in which we reversed it, trained on Accord and validated on Sprint, and did combinations of the two trials, an internal sample and a prospective holdout sample, which didn't result in many differences. A few variables were included in our benefit harm score, variables that are not particularly surprising, but perhaps the keys are the interaction terms, suggesting, interestingly, for instance, higher benefit among people of older age, though it may relate to the overall cardiovascular risk, and somewhat lower benefit and higher risk among people, for example, with renal failure or already treated fairly aggressively with other cardiovascular medications. Let me show you in visual form what the risk score would imply. Among people who had the highest predicted net benefit, the intensive treatment, meaning treatment to 120, tended to have an absolute risk reduction on the order of a 3% absolute risk over 5 years reduction, and no substantial or meaningful increase in harm, but the converse was observed among those who had the lowest predicted net benefit. That is, no meaningful treatment reduction from treating to 120 rather than 140, but an increase in treatment adverse events. Note that these individuals were already predisposed to a higher cumulative hazard of severe adverse events even on 140, which indicates a property of the person, perhaps, in the context of, for example, renal disease. Putting this in numerical terms, among those most predicted to benefit and least predicted to harm, we found an absolute risk reduction among them in the observed case of about a 4% absolute risk reduction over 5 years. Conversely, among the lower tertiles of the risk score, there was a distribution of benefit that in a conventional sense was not statistically significant, but notable increase in harm. When tested in our validation set of Accord, one saw a similar pattern, but interestingly had a higher predicted benefit among a subgroup of Accord, despite the trial's overall neutral or null result. So similar results, but a wider spread of benefit versus harm in Accord. One way to visualize this is here's the predicted probability of absolute risk reduction in cardiovascular events and deaths, what we hope to reduce, where negative numbers are better in the sense of reducing your absolute risk. And on the y-axis is the predicted probability of serious adverse events when being treated to 120 instead of 140. So we would hope those are closer to 0. One might interpret this graph as suggesting differences in sampling. In the Sprint case, one has a narrower pool of people in which we see more reduction in cardiovascular events and similar increase in adverse events. In the Accord set, however, a broader distribution centering around 0. Perhaps one explanation for the differences in average treatment effect. One of the important lessons that we learned in the process of doing this was the concern about not addressing collinearity among variables. When we did not use the approach that tried to deal with collinearity assertively, and instead kind of did a traditional backward selection of variables, we were, first of all, able to see quite a bit of miscalibration, especially in the model predicting adverse events, where we might not understand as much as we do, for example, in predicting cardiovascular events. And oftentimes, if we repeated the analysis in multiple subsamples, we were able to see very miscalibrated models and inconsistency that resulted in pretty bad calibration between expected reduction or increase in adverse events and observed increase in adverse events. So some of the findings in this case were that even though one trial was, in a sense, positive, the other null, we in fact found that a clinical score might be able to differentiate in consistent ways between the trials among those who may benefit from therapy and have less harm, and vice versa. And a number of factors in combination rather than any single factor was required to explain these variations, potentially due to hidden HTE. It's important to note some limitations. These were outcomes censored at 5 years, particularly due to early stoppage of one of the trials. And a very important caveat is differences in clinical outcome definitions required us to use some of the disaggregated data and exclude a heart failure outcome because of different definitions between the trials. So that's a pretty important limitation. In retrospect, it would have also been nice to think about this differently than this net benefit score. Different patients may view having a stroke quite differently than being on dialysis, and that may be something we can explore further. One of the things that we're doing in terms of exploring this further are understanding what are the best metrics for our HTE model. One of our lessons was that we often do a calibration curve in a Hosmer-Lemeshow type of way of predicted event rate versus observed event rate, and one hopes to see a nice 45-degree line. But importantly, we learned that, for example, in cardiovascular risk models, thanks to Dr. D'Agostino and others in the room, we know what the good predictors are. So in a model with interaction terms, age, sex, smoking, etc., often dominate the equation. We can predict cardiovascular risk quite well. The interaction terms you could have be very wrong, and yet the calibration curve for HTE might look very good. Instead, can we do expect versus observed change in risk as a different kind of calibration for HTE models? Given the fundamental problem of causal inference, we don't have the individuals change in risk, but we could do it among groups and look at expected absolute change in risk versus observed change in risk, for example, by matching across arms. That in turn presents a problem. We've broken the randomized trial, and one of my biggest things that keeps me up at night, perhaps this identifies me as a nerd, but is the question of what does one do when you break the randomization? The false positives are concerning. And how much hidden confounding might exist to produce a false positive HTE? I really enjoy reading Rosenbaum's work on observational studies and doing a sensitivity analysis to see how much hidden confounding might we have that leads us to a false conclusion. Since we're breaking the randomization of the study through this approach in making subgroups, could we do a similar sensitivity analysis? How much might we have imbalance in an unobservable characteristic before we get a false positive HTE? And as will be discussed next, there's a number of machine learning methods that we are working with, particularly tree-based methods that I think will be discussed later. We've found quite a bit more robustness in capturing interactions while reducing false positives through cross-validation. Finally, I'll end by talking a little bit about individual patient preferences. One of the things we've been working on is that in the case of type 2 diabetes drugs, for which as a primary care provider there's such a proliferation of nice second-line diabetes therapies, unfortunately it was interesting when we saw in JAMA a paper about the emergency room hospitalizations attributed to these new agents, perhaps because those of us in primary care are overwhelmed by the number of options and trying to keep track of who might benefit versus be harmed by each different type of drug. What we're experimenting with in a trial setting is doing a personalized risk estimate for baseline risk. Does the patient want to be treated or not, or how aggressively might we think about doing treatment? That's the classical absolute risk before treatment. And then from individual participant data and network meta-analyses, we can calculate heterogeneous treatment effects across all the possible treatments that are available. What types of people might benefit more or less from each different type of therapy, and then weight it based on patient preferences. I have some patients who really will not inject a medication, something that relates to adherence, and that's extraordinarily important to them. For others, they're willing to inject a drug. Weight gain might be more important, avoiding hypoglycemia, et cetera, et cetera. Different people are different. And using those as weights to essentially estimate the ranking of medications for this individual based on their personalized risk and preferences, and particularly the uncertainty in those estimates. So that, I think, is on the horizon. I'd like to acknowledge the work of those who worked with me on this, particularly my colleagues Jeremy Sussman and Rod Hayward, and the funding from the NIH. Thank you.